be good to go over it, and we'll discuss the major issues. So just remember, we'll go over these objectives. Important thing is recognizing that somebody's presenting with meningitis. You got to think of the important organisms, and then you can think about your appropriate therapy accordingly. And we're going to talk about just the steroids a little bit, and we'll discuss some cases to understand better. So meningitis, there could be benign types of meningitis. It's like a mild viral meningitis. There could be like more serious fatal cases. So you always have to take this seriously because you don't know what it's going to turn out to be. Okay, so just important definitions, right? Meningitis means inflammation of the meninges. What is the meninges? Meninges is mainly the pia mater and subarachnoid matter. The arachnoid matter and the pia mater. So the dura is not included. The dura, if it's included, they call it pachymeningitis sometimes, right? Encephalitis is infection of the brain parenchyma. So that's an important distinction between meningitis and encephalitis. Meningitis is just the layers. Encephalitis is the actual brain tissue. Meningoencephalitis is both. Aseptic meningitis is when you do not find bacterial organisms in the CSF. It's a sterile CSF. So the pia mater and the arachnoid matter, as you'll see in this photo, this is the brain tissue, this is the pia mater, this is the arachnoid. Dura is usually not involved, but it can be involved, and they call it pachymeningitis. But usually meninges, arachnoid, and pia mater. These are that are very adherent to the brain. Of course, the causes are varied. So they can be viral, bacterial, they can be autoimmune, like sarcoidosis or Behçet's disease, SLE, and such. Okay, so encephalitis is not exactly encephalopathy, but encephalitis will lead to encephalopathy. So if you've got somebody with a fever and symptoms of an infection and they are encephalopathic, then you could say it's due to, it could be due to an encephalitis causing the encephalopathy. So you have herpes simplex, for example, a famous virus that you can detect with PCR analysis, and you can treat it with acyclovir. There are other causes like arboviruses, like dengue, rabies, listeria or cat scratch disease, so less common. So going on to aseptic meningitis, mentioned there's usually no bacteria, but what do you find in the CSF when you do a CSF analysis? You'll find lots of white blood cells, is what we call pleocytosis, when we have a lot of white blood cells with normal glucose and protein, but a negative culture. So although these white cells are high, because the normal white cell count should be less than 5, but now you're getting it high over the hundreds. But levels that are higher than that would indicate actually septic type of meningitis, something with bacteria. And then the glucose and protein would be disturbed. Enteroviruses are the most common cause for this aseptic meningitis. And then it becomes called a viral meningitis once you discover the organism. It's the most common cause, usually about 80%. These tend to cause gastroenteritis in children or just cold upper respiratory tract infection in a lot of people. Herpes simplex virus type 2 can also cause an aseptic meningitis. Dengue fever, Zika, chikungunya, and yellow fever, all these can cause aseptic meningitis. Can HIV, when the person is at the time of the infection with HIV, within the first week or two of occurring the virus, they could develop an aseptic meningitis picture. Partially treated bacteria, that's important because a lot of times patient have meningitis at the same time they have pneumonia. So they might get treatment for the pneumonia, but develop meningitis, but you don't find any bacteria in the CSF. So they call it an aseptic meningitis, but it's a bacterial meningitis, but it turned aseptic. They sometimes call it partially treated meningitis. And certain drugs like metronidazole, trimethoprim, sulfamethoxazole, NSAIDs, and carbamazepine and IVIG. So the symptoms of bacterial meningitis, usually quite apparent. There's a high-grade fever. The headache is prominent and it's usually severe. There may be a change in level of consciousness and irritability and photophobia. So although it is meninges, right, it irritates the underlying cortex, the underlying tissue. Right? It's not really inflamed, but it can be irritated and give you some signs of altered level of consciousness and irritability. In addition, there tends to be an increase in the intracranial pressure, which can contribute to this further. Vomiting, seizures, stiff neck. Okay, stiff neck is a sign of meningeal irritation from anything, right? It can happen in subarachnoid hemorrhages. Bulging fontanelle in infants. As you might recall from your pediatrics, children their skull has not fused in this area, so it's still open, and it takes time, until it fuses. But in that period, when it's open in this space, you can get a bulge when there's increased intracranial pressure. All right, so of course there will be fever on their neurological exam, and neck rigidity or neutral rigidity. You want to move their neck, it won't flex nicely like that. They will kind of move together. Koenig sign and Brudzinski sign. These are two important signs for assessing involvement of the dura or the meninges. So with Koenig sign, the patient is lying on their back. You flex the hip, okay? Flex the hip all the way. And then you have the knees flexed too. And then you start to straighten the leg up. You bring the foot up. فالمريض جالس على ظهره, his hips are flexed and his knees are flexed, okay? And then you try to extend the knee. This will cause pain and will limit your ability to extend it further. Brudzinski sign, there's flexion of the neck will lead to involuntary flexion of the knee and hip. So with Koenig sign, you extend the leg up while the patient's lying on their back. With Brudzinski sign, the patient is lying on their back and you flex their neck. When you flex their neck, you see the knee and hip kind of flexing with it. These techniques both stretch the meninges, and these cause the irritation. This results in this type of reaction. Papilledema. All right, so papilledema is swelling of the optic disc in the eye. You need an ophthalmoscope, look inside the eye, and you look at the optic disc. You see if it is swollen, and that would say that there's increase intracranial pressure. Could happen with anything that causes increase intracranial pressure can cause papilledema. And and if there is a neurological deficit, if somebody has a neurological deficit, that's a major sign. It might involve to indicate that there's actual parenchymal damage, actual brain tissue damage. And as I mentioned, there's usually a source of infection. Could be the ear, sinuses, the lung, the heart. You can have a septic infection in the heart, in an artificial valve, especially the artificial valves, mechanical valves, somebody with infective endocarditis, and then they shoot a septic embolus that can go to the brain, can cause a stroke, can cause an infection, or just be a source of sepsis and cause meningitis. Petechian ecchymosis usually happens later on. It's a very severe stage. All right. So when you don't have the signs, that's usually good, okay, that there's no signs of meningitis, and there's no fever, neck stiffness, or altered level of consciousness. Changes in the mental status are more common in bacterial than viral meningitis, just because bacterial is a much more aggressive process. Koenig and Brzezinski sign have low sensitivity but high specificity. Okay, so something's got low sensitivity but high specificity means what? Means if you find it, then it's likely true because it's highly specific. So if you find it, there's a small chance that there is no, like when you find neutral signs of neutral rigidity and irritation, then there's a good chance that this is meningitis. Okay. Low sensitivity means that there's going to be a lot of people who might have meningitis but won't have the sign. But if they have the sign, then that probably means they do have meningitis. The other one is a jolt accentuation maneuver. You ask the patient to rotate his or her head horizontally, and the headache will worsen when they move their head right and left like that. All right? That is a super sensitive test. It's likely to catch it. However, the specificity is low. So you're going to get a lot of people who say, yes, I have it. My headache is worse when I do this, but they don't really have meningitis. So if you've got a positive headache accentuation maneuver and you've got a positive Koenig or Brzezinski, that's very suggestive. That's very high sensitivity and specificity for meningitis. So what kind of complications are we going to look for from meningitis, right? The inflammation is happening in the brain. So we talked about some of it. We talked about papilledema being due to increase intracranial pressure. And so increase intracranial pressure is also known as hydrocephalus sometimes, when you have too much fluid, trouble with drainage of fluid, drainage of the normal CSF fluid. Seizures, syndrome of inappropriate ADH secretion, effusions and empyema, all the inflammatory material, septic sinus or cortical vein thrombosis. Septic sinus, we're talking about cerebral venous sinuses, okay? Ischemia or strokes can happen. Cranial nerve palsy, especially deafness. Septic shock, multi-organ failure, and risk of adrenal hemorrhage with hypoadrenalism in advanced cases of sepsis. And forgot to mention also brain abscesses can happen. All right. So your basic investigations are CBC, creatinine, electrolytes. You want to check sodium for looking for SIADH. The blood culture is paramount in these cases. Chest X-ray to look for a source of infection, CT scan of the head, and a CSF analysis by lumbar puncture. All right. So when you do your lumbar puncture, make sure there's no signs of infection on the skin where you're going to put your needle in, and the patient doesn't have any bleeding disorders. And you want to make sure that there isn't sort of a pressure gradient or increase intracranial pressure. Because if a person, for example, has a tumor or has a brain abscess, inside the skull, there will be increased pressure. And so if you do a lumbar puncture, you will suddenly decrease the pressure and the brain could herniate downward. And this could be dangerous. So be sure not to do this unless you've obtained an image of the head. So generally, patients with suspected meningitis require brain imaging before the lumbar puncture. So there are some warning signs that may really make you insist to get this image before the procedure. When there's altered level of consciousness, when there's a focal deficit, somebody's got weakness on one side, for example, when there's papilledema or cranial nerve palsies, which would fall under neurological deficit, but similar, papilledema, that suggests increased cranial pressure. seizures, or any neurological deficits in general. Okay, so these would make you definitely be certain to get an image. But generally, you should always get an image before your procedure if you can. CSF analysis. You want to look at the appearance and opening pressure. Sometimes the appearance, the CSF looks like water. Normal CSF, when you get it out, it'll look like water in a test tube. And so if it does not, if it looks hazy, cloudy, grayish, yellowish, then there's something in it, right? Either too much protein, either inflammatory material, either blood. So you want to check the opening pressure. Opening pressure is something you measure at the time of your lumbar puncture. The time the needle goes in, you measure the pressure. What's that's going to tell you if it's elevated or not. You want to do the cell count with differential in the CSF, see how many cells are there. You want to look at the glucose and the protein, right? Glucose will tend to drop with bacterial infections, and protein will tend to increase from destruction to the myelin. CSF appearance, as I mentioned, we'll look at the gram stain under the microscope and the culture, so you know what the organism is and what antibiotics to use. And you can send for tuberculosis as well. Send it for its acid-fast bacilli smear, and for its own culture. You can also do a PCR. And then you've got Brucella serology if you're suspecting Brucella, and for herpes simplex, send for PCR. Viral multiplex viral PCR is a type of PCR that will look for HSV and a few other viruses. Cryptococcus antigen, which is a fungal infection, particularly seen in those with immune suppression. Okay, so just looking at here what to suspect when, according to what you find in your CSF. Right? So these suggest bacterial meningitis. The first one is key. When you have more than 1,000 cells, you would think of a bacterial meningitis, even if your culture comes back negative. If you look at the second one, let's say your CSF came negative, but the leukocyte count is lower in the hundreds, 100, 200, 300, but there's a high neutrophil count. For more than 50%. So that'll make you think that there's a bacterial problem. If the glucose is really low, especially less than 40% of the CSF, of the serum glucose. So you want to take the serum glucose, test it, just take the blood sugar from a patient, test it, and see how it correlates with the blood sugar in the CSF and the CSF protein. High protein would indicate that there's destruction going on and proteinaceous material accumulating in the CSF. All right. Important pathogens. It is different according to age. In neonates, you worry about group B streptococci, E. coli, enterococci, Klebsiella. Older infants and children, you worry about Listeria Monocytogenes and Streptococcus pneumonia, and Mycobacterium tuberculosis and Haemophilus influenza. Causes of bacterial meningitis in adults. So we've got Streptococcus pneumonia is the most frequent one, followed by Listeria Monocytogenes. Then it is Listeria Monocytogenes, and then other Streptococcus species or gram-negative organisms, as well as Haemophilus influenza. Haemophilus influenza is more in the elderly. We might see it recur. All right. Haemophilus influenza is less than before, given the presence of adequate vaccination. All right. So, how do we start treatment? So you want to give higher than usual doses for other things. So ceftriaxone. Ceftriaxone is used because it's initially will cover organisms that might have some resistance to penicillin. So ceftriaxone, 2 gram IV, Q12 hourly. Good penetration to the CSF. Vancomycin, about 500 to 750 milligram IV, Q6 hourly. This is very good for very penicillin-resistant organisms. Dexamethasone. So remember, when I say empiric treatment, it means I don't have an organism yet. So I'm going to start treatment based on my best judgment. Dexamethasone can be used for 2 to 4 days. First dose is 15 to 20 minutes prior to or concomitant with the first dose of antibiotic. It helps blocking TNF production. TNF production is pro-inflammatory, so it reduces the inflammation. Ampicillin for Listeria is particularly used when you suspect Listeria Monocytogenes infection. This is a good management algorithm you should be familiar with. It will help you when you're managing cases. When somebody asks a question about management time related to lab results, if labs are going to be late, by all means, start treatment right away. أهم شيء يعني if a patient comes to you in emergency, get the scan done immediately, do the lumbar tap right away, spinal tap right away, and then you can start your empiric treatment until the results come. Sometimes, for some reason, we even start treatment before we get the investigations if we think there's going to be delay. All right. All right. So this is a good review of when to start treatment. A lot of time right here, you're at this blood, you're doing a lot of times we're doing empirical until we get the results. All right, let's look at a case. A 34-year-old man returning from Hajj has fever, severe headache, neck stiffness, vomiting for 2 days, found confused by family. Temperature is 38.4, heart rate is 110, blood pressure is 100/70, obtunded, neutral rigidity, Kernig's and Budzynski sign, and he's got petechia. So this person is coming with all the features. And the key thing that'll tell you what the organism is that he's coming from Hajj. Do you know what organism is associated with Hajj? Hajj is usually associated with meningitis. Yeah, somebody mentioned it, with Neisseria. All right. So associated with Neisseria meningitis, usually meningococcal meningitis. And this is a sign of the petechia that can happen. This is usually a late stage. You don't want to reach this stage. This indicates there might be some sepsis and the patient might need to be admitted to the ICU. So when you do your examination, the opening pressure is going to be high. The normal pressure should not be more than 200 millimeters of water, but it could be high in this case. And the CSF looked cloudy, probably from all the inflammatory debris. White cell count, 1,500. As I mentioned, it should be less than 5. And 96% are polymorphs. Polymorphs here neutrophils. So two things that point towards polymorphs. Glucose, 24 milligrams per deciliter. We said less than 30 is low. The other thing is to compare it, it should be less than 40% than the serum glucose. If that's the case, that will also point to this being significant. And the protein is high, around 200 milligrams. Usually it's around just 50 or 60. So, and you find gram-negative diplococci in the microscope. This is just an interesting fact or trivia, where this is a zone where epidemics of Neisseria meningitis may actually occur in this area called the meningitic belt or the meningitis belt. We've talked about its relationship with Hajj. Okay, so there is a vaccine for this type of Hajj that you have to take before coming to Hajj. For this vaccine for this type of meningitis that you need to take before coming to Hajj, and this has helped significantly in reducing the outbreak of Neisseria meningitis. All right. We mentioned it could be fulminant with overwhelming sepsis, with DIC, diffuse intravascular coagulation, meningitis with rash, and mortality goes up. And just some additional pictures of meningitis rash. All right. So treatment and chemoprophylaxis. So you have to isolate the person for 48 hours. 48 hours from starting the antibiotic, right? They start the antibiotic, and that's the time we determine how long they need to be isolated. You want to start with ceftriaxone or penicillin G for 7 days. And you have to eradicate nasopharyngeal carriage. So if you get a vaccine, this is a situation where you can vaccinate a person from Neisseria, but they may still transmit it if they have a nasopharyngeal carriage, if the organism lives in the nasopharynx. So you would start them on rifampin, 600 milligrams for 2 days, or ciprofloxacin, 500 milligram just once, or ceftriaxone. All right. And then there's a let's talk about, we'll skip this slide. Okay, let's go to the next slide here. All right, so this is a female who presents with fever, cough, and headache for the last 3 days. Examination reveals an ill-looking woman with signs of consolidation over the lower lungs. Okay, consolidation particularly on the left side. 6 hours after admission, her headache became worse and rapidly became obtunded. Did a lumbar puncture. Look at that. White cell count is 3,000. Polymorph, polynuclear leukocytosis with neutrophilia, right? And that's 99%. And the sugar was 0. That's really low, okay? Protein was around 260. All right. What are we looking at here? We've got very high count of white cells, around 3,000. The white blood cells are not lymphocytes, they're neutrophils, all right? So I see some votes are coming in on the chat, and they're coming in as a bacterial. I agree. With such low sugar, high cells, very classical picture for bacterial meningitis. All right, so we're going to look at the gram stain. Let's say this person's, let me just make sure we covered everything here. Yeah, glucose was 0, everything's okay. So Gram stain showed gram-positive diplococci, and once you hear gram-positive diplococci, you're dealing with Streptococcus pneumonia or Pneumococcus, which is the most common cause and has a very high mortality, 20-30%. And these people are associated with pneumonia, could be associated with otitis media or sinusitis. Could occur after a head trauma, or if there's a leak of CSF that happens after the head trauma, where there's a connection between the nasopharynx and the base of the skull. Splenectomy puts a person at risk for these capsulated organisms, and sickle cell disease does, because sickle cell leads to autosplenectomy sometimes when they have too many infarcts. And there's a global emergence of penicillin resistance as well, so that's something to be aware of. This is a person who had a CSF leak from the ear, probably after trauma. All right, so the treatment, same thing. You're going to start with ceftriaxone, but if you have like culture that indicates it's sensitive to penicillin G, you can do that. So penicillin G, you can check its degree of, measure its resistance to penicillin. So if it's very low, then you can use it, but otherwise you cannot use it if it's higher. You're going to use the ceftriaxone. If it's very resistant, you're going to go to Vanco as well. So this is an important thing to think about when you're treating a meningitis. So treatment and prevention of pneumococcus meningitis. You're going to have penicillin, ceftriaxone or vancomycin, and steroids as well. Steroids has to be given early for 2 to 4 days from the first dose, before the first dose of antibiotic. There is the vaccine that is used for people who, for example, have had a splenectomy or sickle cell patients. They should get this vaccine to prevent them from pneumococcal infections. So there are different types of conjugate vaccines. We don't need to worry about this. All right. Okay, so this talks about dexamethasone or steroids in patients with bacterial meningitis. And you can see at this survival curve, those with placebo had less survival compared to those who were receiving dexamethasone. All right, 70-year-old man in this subsequent case, he has malaise, anorexia, weight loss of 7 kilograms over 1 month. Underwent colonoscopy prior to symptoms onset. Watery diarrhea 4 times a day for 1 week. Fever, chills, and headache for 3 days with double vision for 2 days. In addition to neck stiffness and jolt accentuation and 6 nerve palsies. So this is a different type of organism, not Pneumococcus, not Meningococcus. So what we'll do is proceed to the investigation. So whenever you hear like GI symptoms, diarrhea, that would make you think of a particular organism that might be related to this. One moment, please. Okay. Okay, so I see a couple of suggestions on the chat, which is good. Got some for Listeria, some for Haemophilus. Okay, good. So let's look at the CSF. The white cell count is about 1,000 and 70% lymphocytes. and the glucose is 50, and the protein is 170. All right. So if we've got a high cell count, like 1,000, we're going to think of those typical bacterial infections. Those typical bacterial infections, I would expect to have mainly neutrophils. But when I look at the differential, I take a step back. Okay, wait a minute. These are not neutrophils. So maybe it's not going to be Streptococcus pneumonia or Meningococcus. The glucose. So I don't have the serum glucose here, but I'm going to say that it is on the low side, but not as extremely low as we saw in the previous cases. Likewise, the protein is high, but not as high as it was in those previous cases. So it almost looks like it could be bacterial, but a less intense bacterial process. So again, come on, you have the lymphocytes. That is not typical. So not all organisms have the same pattern. And we have the history of the diarrheal illness. Okay. So looking at the gram stain, we see gram-positive bacilli. This is Listeria. Now, could this be a viral infection that gives you this picture? See, somebody's asked about that. And I agree. I would consider viral in the differential. The thing that would go against viral is that I usually don't see the cell count reaching up to the thousands. Might happen, but usually not. But definitely viral will have a high lymphocyte count. وحتى lymphocytes feel viral, especially when you hear somebody's had diarrhea, you might think they had a gastroenteritis or something. So absolutely, I mean, viral is not excluded. But we have other signs now that are pointing to this. We've got a culture that's positive now, but before that, we would think about viral as a cause. The other thing is we've got a person with 6th nerve palsy on the examination. Sorry. Okay. Double vision and 6th nerve palsy. So this could happen due to increased intracranial pressure or due to inflammation in the brain stem. Now, Listeria is pretty famous for causing inflammation in the brain stem. It can cause increase in intracranial pressure as well, and that can also give you a 6th nerve palsy. And colonoscopy is important because it sometimes is associated with hematogenous spread of an infection. Somebody mentioned pregnancy, and that's true. They are at risk groups: pregnancy, immunocompromised patients, alcoholic. These are people who are at risk. Mainly foodborne sources sometimes. Cold meats هذه زي المرتديلا والهوت dogs أحيانا. Also, they can occur through transplacental transmission. And as I mentioned, sigmoidoscopy can cause bacteremia. All right. So Listeria Monocytogenes, meningitis treatment. Ampicillin. If you're suspecting Listeria, you're going to start with ampicillin plus minus gentamicin for about 21 days. Penicillin allergy might happen, and so you can use trimethoprim sulfamethoxazole. All right. In this case, we've got a 56-year-old Indian man who presents to the infectious disease clinic with a low-grade fever and night sweats for 6 weeks and headache for 4 weeks. His temperature is high now, 38.2, speaking well. but he's got some trouble moving his eyes. There's some ophthalmoplegia. And there's some neck stiffness and also bilateral papilledema. So something is causing an increase intracranial pressure. So if you want to go over some of our clinical exam, you can see the left eye, this eye is middle. This left eye is a bit lower than that eye and it's outward, lateral. So it has failed elevation and failed medial movement. So it's probably indicating a third nerve palsy, especially when you see the eyelid dropping, ptosis, because that's also supplied by a third nerve. So this is a third nerve palsy likely. All right. You do a CT scan, you see multiple lesions. Okay, you see first of all hydrocephalus. These ventricles are large, and you see these ring-enhancing lesions here. You manage to get a CSF. Mind you, if you, in this case is for teaching, but if you get a CT scan with this picture, this is where you wouldn't want to do a CSF, a lumbar puncture right away. You may be forced to treat this patient empirically or see if you can get an idea about the infection through another way. All right, so CSF is xanthochromic. Xanthochromic means it is not clear, okay? It looks yellowish. White cell count is 340. And it's predominantly lymphocytes, 85%. Protein is high, 1.5 gram. And the sugar is 25, also low. And gram saying no organism. All right, let's look at this again. Could this be viral? Let's see. I mean, 340 could be seen in viral. Sometimes lower still, but you know, I'd say yes. Predominantly lymphocytic, okay, sure. That can go with viral. But the protein is a bit too high to be seen with viral. The sugar is too low to be seen with viral. Right? So what other kind of infection that is a bit chronic can do this? Yeah, I agree with the suggestion of checking for acid-fast bacilli. And so when you do, sometimes you need to do multiple specimens to confirm the test. But tuberculosis infection is a possibility. Sometimes you want to take fluid from the at the end of the analysis because you're more likely to capture the organism. And then you get the culture, it's a gold standard, but you can also do PCR testing to determine the presence of, to determine the presence of this. Okay. So someone asked about doing lumbar puncture. As I mentioned early on, if you've got increased intracranial pressure and you think there's an obstructive hydrocephalus, he's got large ventricles. I need to see the whole scan to be sure, but he's got large ventricles. I would think he might have an obstructive hydrocephalus. If his hydrocephalus is obstructive, يعني ما في تصريف من CSF from the brain down to the spinal cord, if I do an additional lumbar, if I do a lumbar puncture lower down, that creates a big pressure gradient and the brain is going to get shoved down and the person is literally going to have downward brain herniation. All right, let's look at some, we talked about this. All right. You've got the method and how an infection starts from a TB infection because it has a droplet infection. It can be either a brand new droplet infection or it can be from a primary focus existent within the body and can lead to multiple problems. I'll let you look at this graph later. This is a tuberculoma in the basal ganglia, right here. Other pictures of tuberculomas. So these are the drugs for TB, same drugs used for pulmonary TB. Isoniazid, rifampicin, pyrazinamide, and ethambutol. You also use dexamethasone in this case. Treatment with dexamethasone associated with reduced risk of death. Okay, you also have a similar Kaplan-Meier curve that suggests the benefit of dexamethasone. All right, let's come to this case. So really, I think this picture kind of tells you the diagnosis already. So a 30-year-old Saudi sheep herder with 3 weeks headache, blurred vision, looks uncomfortable, temperature is 38.1, jolt accentuation is present. So that's suggesting there might be some meningeal irritation. But this is not an acute case, right? He's got 3 weeks history, right? His temperature is up 38.1. You do your lumbar puncture. There's an increase in cells, about 105, mostly lymphocytes, bardo. It doesn't look like those typical aggressive bacterial infections. But the glucose and protein are normal, and the gram stain is no organism. So really, you look at this, you think could be viral. This is a picture of a viral meningitis here. But you know what? Viral meningitis won't go around for 3 weeks, much shorter than that. Right? So you have to think a bit more broadly. Plus, he was pulling a camel. So you have to ask him the magic question, and is that, do you drink raw milk? Even if he doesn't drink raw milk. It could be just from the association with the camels and the sheep sometimes. And so you do your LP and get the results to look for brucella. You can do a brucella titer in this patient, and his brucella titer will be elevated. And this will support your suspicion. And you can do PCR and CSF. In brucella culture, there'll be no growth. That's not surprising. It sometimes happens. And so it's got its own treatment with doxycycline and rifampin and ceftriaxone. So you might have to repeat the CSF in the future to make sure that the patient clears it up. So if you have an HIV patient, right, presenting with 3 weeks of history and forgetfulness, and change in personality, it sometimes happens, presents with generalized seizure to the ER. After he's stable, you do your scan, and there's a mass here with enhancement and contrast enhancement or ring enhancement contrast. And this is a large area of edema surrounding it. So you're concerned about some type of abscess. And you know this person has HIV. So there are certain infections that come in the immunosuppressed in the brain, right? So CD4 is test for HIV. This was probably covered in your infectious disease courses. So I'm not going to go in this in much detail. But you got your CD4 count is low, around 77. The viral load is high. HIV virus is high. And toxoplasma is positive. Toxoplasma is an opportunistic infection in patients with HIV. All right, and so you want to treat them with multiple drugs for these patients. And then you want to reassess after 6 weeks of treatment. You can also give prophylaxis to these people until their immune composition restores back to normal. All right, and then you can do primary prophylaxis as well in these cases. All right. This is a patient who's 46 years old, fever for 1 week, headache for 3 days, and has a prosthetic aortic valve replacement. Remember when we talked about this in the beginning, somebody with the heart as a source of emboli. It could be embolic strokes or it could be septic emboli. So the temperature is really high, the blood pressure is on the lower side, he's got papilledema, So this person actually has what looks like a very well demarcated circle on the MRI area of enhancement. This could be even an abscess, but there's not a lot of edema. Actually, there is edema, sorry, and as you can see that there's midline shift of the brain going this way. So most important is you want to get a blood culture. This blood culture showed Staph aureus. Staph aureus is important in the differential because you get that patients with mechanical valves. The TEE, which is the transesophageal echo, will show you that there's any vegetations in the aortic valve or not. And you'll have to drain this abscess a lot of times, so they'll need neurosurgical intervention. And you treat with cloxacillin and Flagyl. All right, so brain abscess in general, they're most commonly streptococci, but could be bacteroids and enterobacteria or Staph aureus, depending on the cause. So larger abscesses that are more than 2.5 centimeters, you want to do surgical drainage. All right. Antimicrobials, empirically ceftriaxone with metronidazole, otherwise according to the susceptibility. Okay. Remember, metronidazole is Flagyl that I mentioned earlier. Duration, depends on the response by neuroimaging, so you follow these patients closely. Subdural empyema. These are usually extensions of inflammation from the sinus or otitis into the subdural space. And sometimes you need to do surgical drainage for these cases. And I don't think we need to worry about this case here, these last two cases. We'll take, these won't be needed. Okay, all right, very good. I think covered yeah, this image here showed the edema. That wasn't showing on the other MRI picture just because of the type of sequence, but this is an abscess with edema. And here's the other MRI for a different patient. There's an abscess, but you can't appreciate the image just because of the sequence. If you do a different MRI sequence, you can appreciate the edema around it. All right. And somebody asked a question about doxy alone, and probably asking about brucella. You did know it's better to give multiple drugs than doxy alone. All right, are there any other questions? Or shall we take like a 10-minute break before we go to the next session? All right, we'll do that. I'll see you in about 10 minutes, inshallah.